I'd like to introduce myself. I'm Elizabeth Buck, President of the student body here at Iowa State. I'd like to welcome all of you to Iowa State University and to this discussion on health care. The National Retired Teachers Association and the American Association of Retired Persons and the Iowa State University government of the student body have worked together in co-sponsoring this session. For we feel that the issue of health care costs is one that affects all Americans. The purpose of this forum is to focus the attention on the health care needs of all Americans and how these needs are currently served, to stimulate public discussion on alternative health care programs, legislation, and activities, to mobilize support among participants for health care programs that respond effectively to the needs of the community, and to identify the practical roles for participants who wish to become active in grassroots efforts to improve health care for all Americans. We have three very qualified and interesting speakers this afternoon. Max Fine from the Committee for National Health Care Insurance, Kirk Stromberg, who is the legislative representative for the NRTA and ARRAP, and lastly, Congressman Tom Harkin from the 5th District of Iowa. I will be unable to listen and stay for the speeches this afternoon because I have a 3 o'clock class here at Iowa State, but I would like to yield the floor to Max Fine from the Committee for National Health Insurance.
Thank you, President Bach, fellow panelists, ladies and gentlemen. I'm very happy to be here on such a beautiful day in Iowa. I gather this is not standard December weather. It's nice to be on another university campus, although strange things often happen to me on university campi. I was invited out to the University of Notre Dame recently. The Medical Society from the state of Indiana invited me to come out and speak at a dinner they held at the University of Notre Dame. They have this very nice, beautiful athletic and convocation center. It's all indoors. On one side is a track and field, on the other is basketball, and in the middle was the dining area where they held the dinner. And most of the people attending were physicians and their spouses. The chairman of the dinner was the president of the Medical Society, who introduced me, and I got up and gave my canned talk. And when I finished, a gentleman sitting right at the front table stood up and said, I'm Dr. Shelton, and I want to say to you, Mr. Fine, I think you've got a lot of gall coming out here. He said, who do you think you are to come into our community and tell us how medical care should be practiced? He said, you're trying to intimidate us, and I, for one, won't stand for it. And at this point, the chairman, the president of the Medical Society, leaned over to me and said, ignore him, he's a dentist. And we had a good time after that. Well, I think that this audience is generally aware of the fact that national health insurance proposals have been around for a long time. As a matter of fact, the first American president to suggest national health insurance was Theodore Roosevelt in the Bull Moose campaign of 1912. And the first sitting president to suggest national health insurance was Woodrow Wilson in 1916. But in 1920, shortly after the Soviet Revolution in Russia, when proposals were made to bring the issue of national health insurance to the Congress, the American Medical Association mounted a campaign around the country calling national health insurance Bolshevism, and that ended that particular legislative effort abruptly. It wasn't until 14 years later, when the late President Franklin Roosevelt brought the Committee for Economic Security to Washington in July of 1934 to help plan and recommend what became the original Social Security Act, which was introduced in July of 35. One of the major recommendations of the Committee on Economic Security, along with the old age pension plan and workmen's compensation and unemployment insurance, was national health insurance. And the American Medical Association called it Soviet medicine, and they sent the president's own physician, Dr. Ross McIntyre, down to see him at Warm Springs, and they warned the President of the United States that if he didn't pull that piece out of the package, that the AMA would rouse the doctors in the country to fight against the old age pension plan and the rest of the program. And FDR, with a public announcement that he would study it further, pulled the National Health Insurance Plan out of that package, and it was not submitted to the Congress along with the other elements of the original Social Security Act. Later on, prior to the Second World War, Senator Wagner of New York did introduce a proposal which had the President's backing for national health insurance. But the Second World War came along, and of course that froze activities in the domestic field. During the Second World War, the War Labor Board ruled that while wages were frozen, unions could negotiate for fringe benefits, and the unions began negotiating for health insurance benefits. And that was the real genesis of Blue Cross and Blue Shield and the private health insurance industry. Prior to the Second World War, there had been started in Texas a Blue Cross plan by some school teachers who were desirous of keeping Baylor Hospital open, and they agreed to pay $3 a semester, $6 a year. That was the original Blue Cross premium, $6 a year. And that was the first of the Blue Cross plans. But the real impetus to Blue Cross and Blue Shield came during the Second World War with that ruling by the War Labor Board. And right after the end of the Second World War, President Truman sent as his first domestic message to the Congress a proposal for national health insurance. At that same time, the National Labor Relations Board ruled that employers, even though the war was over, still had to continue negotiating on such things as fringe benefits. Harry Truman was the only president to date to have fought for national health insurance. He fought very hard for it. In his book, Mr. Truman wrote that his greatest disappointment in public life was his failure to enact national health insurance. His plan was resisted even more strongly by the AMA than it had resisted the earlier plans. They spent an admitted $10 million. They sort of coined that phrase, socialized medicine. That's what they called President Truman's proposal. And of course, he was outraged by that, but he couldn't compete with them either. Because the battle for national health insurance is, first of all, a battle for public understanding. And if those scare words are around, socialized medicine, and they still scare people, you hardly can begin to win the battle for public understanding. The AMA hired an organization known as Whitaker and Baxter, San Francisco public relations organization that became famous for defeating the president. They later went to work for Richard Nixon and elected him. When Eisenhower succeeded to the White House in 1953, January 1953, he was asked about national health insurance and said he was opposed to it. However, in the late spring of 1955, the Eisenhower administration did suggest that there was a problem in terms of the elderly, that there clearly was a need to do something about helping the elderly, because that time and all the way up to the enactment of Medicare, when you reached age 65 or when you retired, the chances were 2 out of 3 that you lost your health insurance. And you could work for a lifetime and save up a little money for retirement and have one semi-serious illness and be wiped out. And it happened to millions and millions of Americans. Well, the Eisenhower administration recommended that the Congress provide a $10 million subsidy to the insurance companies so that they would be less wary about retaining people after age 65. but $10 million wouldn't have gone very far even in those days. And besides, the need was much greater than the very narrow type of benefit that the Eisenhower administration suggested. $10 a day coverage in the hospitals was what they would subsidize. And even in those days, a hospital episode cost considerably more than $10 a day. So the people who in the private sector had been several years before that supporting President Truman and his plan sort of regrouped, and in the summer of 1955 they began the effort which 10 years later produced Medicare. Now those people included the late Walter Reuther, then the president of the United Auto Workers, people like Dr. Michael DeBakey, the famous heart surgeon, Mary Lasker, who has done more for medical research and the establishment of the National Institutes of Health in this country than any other individual. People of that stature began the effort for Medicare in mid-1955. In the 1960 presidential campaign, the Democrats nominated John Kennedy, the Republicans nominated Vice President Nixon. Medicare, and some of you will remember this, I'm sure, became a very prominent domestic issue in that campaign. Nixon, who had continued to deny the existence of a problem after he was nominated, with Jack Kennedy proposing Medicare, Social Security hospitalization, came forward with his plan. And his plan, again, was a subsidy to the insurance companies, considerably more money, but it was too little and too late. And the pollsters will tell you that in the 1960 campaign, the Democratic nominee for president, for the first time in the history of the polling organizations, won the majority vote of people 65 and over. And the concern about medical costs and hospital costs was clearly reflected in that vote. After he succeeded to the White House, President Kennedy brought a group, I was very happy to be one of them, together to try to get Medicare enacted. We worked very hard for a number of years, and we weren't getting very far in the Congress. There used to be a very powerful man named Wilbur Mills, who was chairman of the Ways and Means Committee, the House of Representatives, and he just would not hold hearings on the issue. As a matter of fact, I remember when after those years of effort, when the president put the arm on Mr. Mills, and Mr. Mills finally agreed to hold hearings on the Medicare issue, we had a party that night to celebrate. He's holding hearings. We didn't invite him to the party. That wasn't the start of his problems. But just the fact that the legislative process finally had begun was a monumental occasion. It was during those hearings that the assassination of President Kennedy occurred, November 2nd, '63. And one of the first public commitments that the new president, Lyndon Johnson, made to the fallen president was Medicare, hospital insurance for the elderly under Social Security. And now the handwriting was clearly on the wall. The American Medical Association knew that it could not stop this any longer. They came in with their own preferred plan. They called it Elder Care. The states' riders came in with another plan. And in the executive sessions of the Ways and Means Committee, Wilbur Mills put together what he called a three-layer cake. And the first layer was what we'd been fighting for all those years, hospitalization for the elderly as part of their Social Security. And the second layer was what the AMA had come in with in those last few weeks, and that's now Part B of Medicare. That's why, if you've ever wondered why only the doctor has freedom of choice under Part B, it's because that was the AMA's idea. Only the doctor can decide whether or not to accept assignment. And most of them don't. Only the doctor can set his usual customary fees, and there's no negotiation of that. At least there wasn't for most of the years of the program. And the third layer was Title 19, Medicaid, the states' writers' contribution to this. And that's why the states decide who's eligible, the states decide what benefits to provide, and the states pay according to a formula whereby the large states pay 50%, and states such as Mississippi and Louisiana and Alabama and Tennessee and so on pay only 17%, and the federal government pays the rest. So that's sort of a brief background on how we got to where we are now. Where are we now? The Committee for National Health Insurance, for which I work, was set up after Mr. Nixon was elected president, but again by the late Walter Reuther, and it includes among its members the same people who were engaged in the Medicare fight, only now we have a much broader base. There are many doctors on the committee, progressive doctors. All of the senior organizations support what we're doing. The nursing profession, both the licensed practical nurses and the registered nurses, and many others, including the entire labor movement, supports the idea of a comprehensive and universal national health insurance plan. And when the committee was established by the late Walter Reuther and set up a technical committee to develop a bill to present to the Congress, the AMA, which had learned in the Medicare fight that you couldn't beat something with nothing, came forward with its own preferred plan again. And so did the Hospital Association, and so did the insurance industry. But it's also very clear that no plan can be enacted without the active leadership and support of the President of the United States. And Mr. Nixon sort of confused all the issues. He came out for a plan, and then when its flaws were pointed out not only by opponents of the Nixon administration, but by economists and others, he changed that plan. And by the time he left the White House, you didn't know where he was. And lo and behold, Gerald Ford picked up that same mystifying plan and said, let's pass it before the end of the year. The Congress held hearings. Wilbur Mills was still there. And they voted on certain aspects. But clearly, President Ford was only looking forward to the November 1974 elections. And after they were over in December of '74, he said he changed his mind. He really wasn't for any plan. And then we got into the 1976 campaign. And in the Florida primary, Jimmy Carter, the underdog to George Wallace, who'd never been beaten in the South, in the critical primary for Jimmy Carter, campaigned up and down the state, but particularly in southern Florida, and made a very strong commitment to national health insurance. He said, very fine presidents have tried to enact national health insurance. Harry Truman worked his ass off for it. That's one expression he used at one point. He says, and I'm going to get it. I'm going to get it. And given the very large senior population in southern Florida, who really supported Jimmy Carter for no other reason than his promise and his commitment for national health insurance, that carried the day in the Florida primary, and that was the key primary. Well, since he moved into the White House, President Carter has on many occasions made statements about national health insurance. But the bill itself, the Carter plan itself, had the gestation period of an elephant. It took 33 months, and finally, just 2 months ago, it was introduced. And in no way, shape, or form did it redeem the promise that he'd made. He'd promised a universal and comprehensive national health insurance plan. Instead, he's proposed a plan that now resembles the plan that Senator Russell Long of Louisiana wants us to have. What does it mean for the elderly? The biggest problem that the elderly face is the doctors will not accept assignment in most places. There are a lot of doctors in Florida who think that God created people to work all their lives and save up their money and retire to Florida and give it all to the doctors, because they literally do not accept assignment except in the northern part of the state. None of them. Of course, most people retire to the southern half of the state. And the same is true in many other states. So a great big problem, along with the fact that prescription drugs aren't covered, is the problem that doctors will not accept assignment. Well, how do you handle that problem? In our opinion, in the opinion of the technical committee with which our committee has been associated all these years, you have to have a system whereby doctors are entitled to reasonable fees, but these are pre-negotiated by the health plan, and the doctors would not be permitted to charge more than the health plan pays. The patient should never see a doctor bill ever again. Instead, the Carter administration is proposing that Medicare and Medicaid be put into one program, and that the doctors who will treat patients who are in that program would have to accept government-set fees on that part, but could charge everybody else anything they want. And that's just a surefire way to drive the doctors away from taking care of the elderly and the poor. You've got to set this across the board on everybody. You have to have the same system for everybody, because if you say there's a one-class type of patient over here and another class patient over here, the doctors are going to flock to those for whom they can get the higher fees. So the Carter administration's solution to the problem of the doctors not accepting assignment is the wrong solution. Almost goes back to Elizabethan poor law ideas. Medicare was not a health program. Medicare was a humanitarian program. It was designed to take care of this problem of people getting wiped out because they couldn't have insurance after they were 65. Now, when even the AMA's brand new survey that Dr. Gallup did for them shows that 67% of the American people favor national health insurance, this is no time to retrogress to the Jimmy Carter idea of putting poor people and elderly people in one class program and everybody else in another. Now, what about that other part? We were going to have comprehensive benefits, not just universal, but comprehensive. What do we have? The president is proposing that the fellow that works in the campus bookstore or in the pizza parlor or in the ice skating rink or in the cleaning store, these are the people who don't have any health insurance now. The president's proposing that their employer be required to cover them with a private health insurance policy, and the employee could be charged 25% of the premium. The employer has to pay 75%. But there's no benefits, none at all, until the individual has spent $2,500 out of their own pocket. That's called catastrophic health insurance. That's what the president is proposing. And if the Congress were to enact it, it would be a real catastrophe. because not only would it not help the people who have no health insurance, it would force them to pay, and they'd get no benefits until they were already on welfare or already borrowing money from loan sharks to pay the deductibles. But it would create greater imbalances in the health care system than we have now. Inflation would go right through the roof. There would be more and more high technology and less preventive medicine, less early diagnostic services, less coverage for the things that are ordinarily used, more billions put into high-cost things, an open invitation the hospital to keep you longer. The doctors would be less able to resist family pressures to put you in the hospital on the theory that couldn't cost you more than $2,500 and stay longer. It's a bad idea at a bad time when we ought to have leadership fulfilling the promise that every other industrial country in the world except ours and one other has long ago fulfilled. 61 industrial countries have either a national health service, such as England's, which we're not proposing, or a national health insurance, such as Canada's, which we are proposing. The only two who do not have any national health plan are the United States and South Africa. Now, Senator Kennedy has a health plan. I think his is perhaps better known because for years he's been the chairman of the Health Subcommittee, and he's had different health plans. I do not work for Senator Kennedy, and I'm not here to promote his candidacy. I am here to differentiate between his health plan and President Carter's because there's a great difference. The concept of the catastrophic health insurance proponents, whether it's President Carter or Senator Long, is that, yes, we have a terrible problem in medical care, and that is the costs are going right through the roof. And we've got to do something about it. And what they propose to do about it is to make you more cost-conscious than you are now. Never mind that the doctor is the one who decides when to hospitalize. The doctor decides what x-rays and what tests to order. The doctor decides when to discharge. The doctor decides what prescriptions you need. And no mention in that bill of the need to make the doctor cost-conscious. Instead, the patient should be made more cost-conscious by having to share in more of the costs. That's the idea of the $2,500 deductible. That's the idea of other bills that are before the Congress. Senator Long has a bill that says you should pay for the first 60 days in the hospital. Only after that will the health plan pay. That way you would resist going in the hospital. I mean, this attack against benefits that have been won is a broad one, and it's a serious one. You may have seen President Carter's Advisory Council on Social Security over the weekend, what they recommended. They recommended that you should pay taxes on 50% of your Social Security benefits. You don't pay taxes on Social Security benefits, you never have. It's an earned right. But there's this broad-scale attack. It's all part of the same attack, and that's to make you more cost-conscious by paying more of your own medical bills. Sure, they'll start with the low-income worker because they're vulnerable. They don't have unions to protect them. They're going to make them pay parts of medical bills. And then right across the board, their idea is to make us all more cost-conscious. What good is insurance if it doesn't pay the bills? The premiums will stay up high and we'll get less benefits. That's the concept that's involved in the Carter plan, in the Russell Long plan, in the Al Ullman plan, and Al Ullman is the successor to Wilbur Mills. Very powerful. He's got the same kind of plan. Now, the entire nation's eyes are focused on Iran. And when they're not focused on Iran, they're on inflation. And in many areas, they're focused on unemployment and the economy. But meanwhile, this is going on day by day in Washington. They're marking up a bill. That means that the committee is deadly serious. They've had their hearings, one day of hearings. They wouldn't let any of the religious organizations testify. They wouldn't let AARP testify. They wouldn't let the National Council of Senior Citizens testify. They wouldn't let the nurses testify. They wouldn't let the unions testify. They held one day of hearings, and then they started marking up a bill. And who's they? It's the Senate Finance Committee, Senator Long in the driver's seat. And sitting there, concurring in what they're doing, are representatives of the Carter administration. What's the first thing they did? They said, well, now, President Carter proposes a $2,500 deductible. But Senator Dole, who's also on this committee, and he's the leader of the Republicans on this committee, he's proposing it should be a $5,000 deductible. He thinks $2,500 is too low. Let's split the difference. All those in favor of a $3,500 deductible, raise your hands. And everybody on the committee who voted, and that was the majority, raised their hands. So right now, that committee has voted for a $3,500 deductible, with the administration concurring. Nobody voted against it. All those opposed, nobody. Now, it's going to sound very politically appealing. The politicians will say to you, we can't do everything. Let's take care of the worst problems. Let's take care of those families with ruinous medical bills. But for the average family, they'd be wiped out before they ever reach the threshold of benefits under such plans. Because there's a lot of things that doesn't cover at all. It doesn't cover prescription drugs at all. It doesn't cover eyeglasses or hearing aids or nursing home costs. Those are totally excluded. You have to satisfy deductibles just on what's covered. And then you have to do it within the framework of usual and customary fees. So for the non-elderly, what it means is the doctor charges $5,000 for a gallbladder, and the usual customary fee is $1,500. All you've satisfied is $1,500 deductible, even though you have to pay the doctor $5,000. That's what they're proposing. Not changing the system, not tampering with the problems in the system, creating no new reforms. We need more than just humanitarian concepts. Now we need a genuine health program that deals with the costs, that does something about controlling them, that improves the unevenness of quality, that creates systems improvements. We ought to be encouraging health maintenance organizations in a real way so that at least they're available. To most people, they're not available. The politicians can read the polls as well as the AMA, as well as you and I can. It's an extraordinary thing, this poll that the AMA commissioned from Dr. Gallup, which was reported in the December 7th, just 3 days ago, issue of the AMA's own newspaper. 67%. That way, 45% said yes. And yet we're not talking about raising taxes. We're not talking about a bill that requires new taxes. We're saying that all the billions of dollars we're now spending for health care, $220 billion this year, over $800 for every man, woman, and child in the country is enough. But let's have a system under which it assures that you're covered whether you're working or laid off, that it assures that you're adequately covered when you're elderly, that covers those deductibles and the co-insurance and the overcharges that the elderly have to pay, covers prescription drugs, does away with the $8.70 a month Part B premium. That's over $100 a year that a lot of elderly can't afford. There's a lot of elderly people in this country that can't afford to buy a newspaper. People who've worked for many years have contributed a great deal to this country, and this country owes them a lot, including decent health care at a price that we can afford. You can't get it with piecemeal programs. You can't get it with the kind of program that Senator Long or President Carter is proposing, and that you're going to hear a lot about because it's politically sounds good. No more ruinous medical bills. When it comes down to your own case, the chances are 99 out of 100 it won't help you at all. Senator Kennedy's plan does cover everybody. There's nobody left out. There's several million left out of the other plans. And everything is covered. The doctor's bill in full, the hospital bill in full, prescription drugs are covered, hearing aids, and so forth. I mean, why can't we have a plan that pays all the bills instead of having to pay it out of different pockets? We pay this much from taxes, and we pay this much for premiums, and we pay this much for deductibles, and so much for co-insurance, and so much for the services that the insurance doesn't cover at all. We're paying the money now, and we have no way to get a handle on the costs. We're saying that doctors who now negotiate only with themselves are entitled to reasonable fees, but let's have a system of negotiating those fees. We're saying that hospitals who are paid on a cost-plus basis have no incentive to reduce waste, have no incentive to be efficient, to keep the costs down, because they're paid on a cost-plus basis. We're saying that hospitals should have all the technology they need, but they should not be permitted to waste our money. We're saying that the insurance companies who take $14 billion out of the system for their part of the operating expenses and the profits should have a reasonable profit, but not on the basis of denying claims, not on the basis of repaying only 50 cents on the dollar for all the individual policies that they sell in the country, not on the basis of the vulture-like companies that have been ripping off the elderly with these Medigap policies. I'm not talking about the good ones that AARP and the National Council provide. I'm talking about those hundreds of others that are just rip-offs that the House Committee on the Aging has documented have stolen $1 billion a year from the elderly because they don't pay any benefits. Our country can't afford that kind of waste and those kinds of rip-offs. We need a system that keeps the provision of care in the private sector, that encourages the doctor-patient relationship, and that removes barriers, whether financial or insurance barriers, that impede that relationship. That's what we need. That's what's embodied in the Kennedy-Waxman bill. Congressman Waxman is the chairman of the Health Subcommittee in the House. Senator Kennedy is the chairman of the Health Subcommittee in the Senate. They are the proper people to lead a congressional effort on national health insurance because of the committee positions they hold, not because of any political campaigns. But this political campaign is going to be crucial on this issue. The people in Washington will tell you that. Even though it's been around for a long time, this political campaign will be crucial because more than 50% of the members of this Congress are sponsoring one kind or another of these national health plans that I'm telling you about. They're either sponsoring the kind that Senator Long and President Carter want, a catastrophic type plan, or they're sponsoring the kind that Senator Kennedy and Congressman Waxman want. They come in different names, different bill numbers, but more than half of the members of Congress, of both houses of Congress, are supporting one or the other. And I think that that reflects the sentiment in the country. Imagine Bob Dole, who cries out against government spending. He's proposing a bill of about $5 billion for catastrophic health insurance. You take all the other bills that he's ever sponsored, they don't add up to $5 billion. And he's been in the Senate a long time. So they know that the public is uneasy. American people really do not have the peace of mind that Canadians have. In Canada, when you get sick, you don't have to worry about the cost. Why should you have to worry about the cost when you're sick? They have a national health insurance plan. And Gallup did a survey up there on his own. And he found that 84% of the Canadian people listed national health insurance as the best of all public services that is offered in Canada. Better than police service, better than fire service. The Canadian people love it. Why don't you hear about it? It's been there for 10 years. And when Canada started national health insurance in 1968, Canada was spending 6% of our gross national product for health care, and we were spending 6%. Canada is now spending 7%, and we're spending 9.3% of a much larger gross national product. We're spending far more for health care than Canadians, and yet in Canada everybody's covered. Nobody loses their benefits, and the doctors have found it to work very well too. At their convention this last July, an insurgent group of about 1% introduced a resolution calling for the repeal of the national health insurance, and that's the vote it got, 1% of the Canadian doctors. So they like it. They fought against it. Senator Kennedy talks about, and accurately too, when the Canadian Parliament was getting ready to enact national health insurance, the Canadian Medical Association, which had used all the same arguments that the AMAs used, finally said, you better not do it. If you do it, the doctors will go on strike. And the Parliament went ahead and enacted it anyway, and the doctors did go on strike, and the death rate went down. So they're not very proud of that, but they are proud of their national health insurance. Thank you very much.
Max has given us a good overview of the legislative history, how national health insurance was initiated as a public policy issue. I'm going to take a few minutes to talk to you about what you can do in helping us to get national health insurance enacted, and how you can work within your own communities and in your own state here in Iowa to initiate some better changes in terms of your own health care delivery system. To kind of reinforce what Max has said, I'd like to talk about 3 or 4 things that I see are problems with the way we deliver health care in this country. The first one Max spent quite a bit of time talking about, and those are the costs. He mentioned to you that we're spending in this year, 1979 in the United States, over $200 billion for health care. It amounts to about $800 to $900 per person. If we continue to spend at the rate that we've been spending recently, in only 19 or 20 years, by the year 2000, we'll be spending $1 trillion. Now, I can't even begin to comprehend how much $1 billion is, let alone $1 trillion. But it'll be, for each one of you, about $5,000 per person, only in a 20-year period. In terms of cost for you who are in the audience who are older, Medicare, which was enacted, as Max said, just a few years ago, is designed to pay 80% of your physician costs and 80% of your hospital costs. You're spending more now out of pocket for those 2 categories after Medicare has been in existence for a number of years than before it was formed. It's only paying 74% of your hospital costs. It's only paying 55% of your physician costs. So you're worse off out of pocket now that Medicare has been in existence than before. Another problem has to do with monopoly. Physicians control about 80% of all health care expenditures in this country. And you and I, we can't negotiate with the doctors for how much we pay for those services. It's fee for service, that's the technical term. You get sick, you go into the doctor, and he tells you afterwards how much your bill is. You can't shop around, you can't deal with the system because there's no competition in it whatsoever. And that's a severe problem, and it's something that's got to be reformed. Third problem that we have in the way we deliver health care in this country has to do with the quality. And we don't have the best quality health care in this country compared to other countries. Two statistics that might bear this out: in terms of life expectancy, there are 6 countries that do a better job than we do. Their citizens live longer on the average than ours do. In terms of infant mortality, there are 13 countries that have lower infant mortality rates than we do in the United States. We spend an incredible amount of money, something like $2.5 billion a year, on unnecessary operations in this country. And there's no need for it, and it's coming out of your pocket and my pocket, and I don't think that's good quality medical care. Access is a problem also, and I suspect that here in Iowa you find that a greater problem than many places. 25% of the people in this country, if we went around the room and counted off in 4s, 1 out of every 4 of you would have inadequate access to medical care. So there are real problems in terms of the way we deliver health care, and it's necessary that we reform that system. And we think the best way, on the national level, is to enact a program of national health insurance and remove some of these problems. But there's some things that you can do on the state and local level. And let me spend most of my time talking about what you can do on the state and local level. I think there are 4 things that you need to know, and there are 2 things that you need to do. 4 things that you have to know and 2 things you have to do to be effective in making political change in terms of health care. First thing, you need to learn how the system operates and how it works. What is the system of health care? Secondly, you need to know who's involved in that system. Who are the principal actors in the way health care is delivered? Third, what are the problems in your local community or in your state with regard to health care? And fourth, learning something about the process of legislation and finding out the process for effecting change. And I'll talk in a few minutes about some of the specifics on those 4 things you have to know, and then I'll talk about the 2 things you have to do in a few minutes. The first thing I mentioned you have to know is, what is the system? How does it work? I think there are a number of things that you need to know about that. First of all, you have to know that there is a very fragmented system. It has little coordination and little planning, and that there is very little competition in that system. Those are kind of characteristics. Okay, who's who is the second thing you've got to know. You've got to know who the local providers are. Who provides health care in your community and your state? Consists of public kinds of operations. The government delivers all kinds of health care. Sometimes the county hospital is the primary provider. There are all kinds of nonprofit organizations that deliver health care. There are private kinds of organizations that deliver health care for profit. And mixed in with that are all kinds of things like hospitals, nursing homes, doctors themselves. They're all providers, but they fall into the categories of either public, nonprofit, or private for profit. But you've got to, in doing some research, you need to find out who those providers are. In addition to the providers, there are all kinds of bureaucrats that are involved in the thing. Planners, for instance. In every part of the country now, there's what's called a health systems agency that was set up as a mandate from the Congress a number of years ago. And they're supposed to do some very systematic planning in local communities, in a number of counties, for instance, so that there's not overlapping and duplication. And they consist of a public board, and they consist of some full-time paid bureaucrats. You folks, if you want to effectuate change in that system, need to find out who's on your health system agency, who the kinds of people are, how they react, how they behave, how they make decisions, and try to get involved in some of the kinds of decisions that they participate in. In addition, there are all kinds of bureaucrats at the state level. Your Department of Social Services, or your Department of Health, or your Department of Welfare, or whatever it may be called in the state of Iowa. They do a lot of health planning. And the kind of day-to-day decisions they make in terms of planning and how they implement regulations have a great impact on the local community on how things happen. And so you'll need to find out how these people operate. Then finally, there are groups of associations of concerned people. And sometimes they're kind of organized on the basis of professionalism. And so you have associations of physicians like the American Medical Association, but there are other physician groups besides the American Medical Association. I think less than 50% of all the physicians in this country right now belong to AMA. And the other 50% are either unorganized or else they belong to other kinds of organizations. And you need to find out in Iowa who those physicians are that don't belong to AMA, the ones who do. Find out who the physicians belong to, what kind of organizations they belong to. There are associations of nurses. There are associations of healthcare providers. And you need, on your local community basis and on the state level, to find out who these people are. Because if you don't know who they are, you can't affect any changes in either their behavior or the kinds of decisions they make that affect you. In working on this little part about who's who in the community and finding out who these people are, you need to not only find out what their official titles are, but you need to find out something about their personalities, their philosophies, their attitudes, because their philosophies and their attitudes determine the way they make decisions and the way they deliver the health care. And you need to find out where the power really is. Who is it that makes the decisions in the community about these things? Is it a local board? Is it a larger group of people, or are there other people who influence it? And it varies from community to community, and the only way you find out is to do some, what they call in journalism, some investigative reporting. You get out and you do a lot of interviewing, and you talk to a lot of people, and you ask a lot of questions. Okay, we've talked about what the system is and how it works and who's who. There are two other things that I mentioned you have to know. One of them, you have to know what are the problems. Again, a lot of research has to take place. You have to ask a lot of questions. I would suspect, based on what I've seen around the country, that in a state like Iowa, that one of the first problems that you have, but you'd have to find this out for yourself and find out exactly how it works in your communities. How difficult is it to obtain good medical services in your community? Do all the people in your area have ready access to emergency medical services so that if they have a heart attack in a farm area, can they get immediate help? Are there alert systems? How difficult is it for people in a small community to get good medical services? How difficult is it for people in the inner part of Des Moines, where there might be low-income areas for people to get good medical services? One of the problems that I suspect you have is that you spend a lot of your tax dollars on educating medical students, only to find that they leave the state to go to some other lucrative market where they can specialize. About 80% of all the physicians in this country specialize. They don't provide the primary care that many of you need on a day-to-day basis. Another problem that you probably have is that it's difficult to receive any medical care at any cost. And so it's not just a matter of a problem that it costs you a lot of money on a day-to-day basis for medical care if you get sick, but you may not be able to get medical care at all at any cost. Okay, then you need to know something about the process for affecting change. How is it that politicians make decisions? And how is it that you can affect their political decisions? So you've got to learn something about the legislative process at the local level and the state level. Got to find out something about the structure of those legislative bodies, whether it's a city council, a town council, a health planning agency, the state legislature. Again, you kind of go through the same process. You find out who's who in that structure, how they make decisions, and what the formal process is. You need to know, for instance, how a bill is written at the local level or the state level. You need to find out things like when are those bills introduced, when are there hearings held on them, what are the critical intervention points in the process? When do you try to influence their decisions? Do you do it in the beginning? Do you do it all the way along, or do you do it at the end? You've got a lot of homework, you see, you've got to do. So if you don't know what those critical intervention points are, you might try to influence decision-making at the wrong time and have less effect. So there are four things that you've got to know. You've got to know what the system is and how it works. You've got to know who's who in the system, what the problems are, and what the process is for effecting changes. Now, there are two things that I mentioned that we also have to do if we're going to make changes happen in the way health care is delivered in this country, both at the state level, the federal level, and at the local level. You've got to get organized. Now, let's talk a little bit about how you can get organized. I think if I were going to get involved in some kind of a local effort to change the way health care was delivered, I'd start at the local health systems agency that I mentioned a few minutes ago. And I'd try to get together with groups of people who think similar to you. And I would start discussing with them ways to form a coalition so that you have a broad base of power out there, not just yourselves. So start discussing with some of your friends in the community and working with other organizations. Find out what the needs are in your community, and then try to develop some very specific plans, set some priorities in some target areas, and make a hard kind of decision. Determine what it is that you think you can change and go after that particular change. You're not going to change the whole system immediately, but there are parts of it that you can. So you might consider working with such organizations as the Area Agencies on Aging. They have professional staff, they have volunteers that have been working in the field, they know how to affect political change. Work with the Department of Social Services people. Work with organizations like the Heart Association, the American Cancer Association, the Nurses Association. Try to get on some of the boards. Blue Cross and Blue Shield are finally starting to open up. For years, the only people who served on their policy-making boards were the providers, the doctors, and the hospital administrators, and a few very prominent kinds of people like maybe a banker from your community. But they're starting to open up the process now. It's a form of open democracy. And you ought to see if you can become a board member of your local Blue Cross or your local Blue Shield plan. The health systems agencies also have boards. See if you can become a member of one of those boards or one of their advisory groups. I know a number of people that I've worked with on state legislation in New Mexico and Texas who have gotten very interested in health care and gotten on the HSA boards and their advisory councils. In addition, try to get on your local hospital board. So there are lots of things that you can do that way in terms of getting organized. But there's some other things that you need to do to get organized. One of them is that you need to teach other people this process and teach them how to become involved. So you'll need to identify people who think like you do, who have an interest in political change and affecting the way we deliver health care. Identify them and train them. Form some study groups. Learn as much as you can about the issues, whether it be national health insurance on the national level, or it be a problem like how can we get better regulation so that there are more inspections of nursing homes in the state of Iowa. You know, that's a real severe problem. Maybe that's one that you could tackle. There are other kinds of problems that you could study at the local level. How could we get physicians to come into our rural area? Or how could we get emergency services into our area? So get some people that you think will think like you, identify them, train them, and start studying those issues and learn about the issue in depth. Set up some telephone networks so that when you identify a critical intervention point in the legislative process or the decision-making process, you can literally flood whoever is working on that issue on a political basis with telephone calls, with letters, and with personal visits at the right kinds of time. So that's one of the things you also need to do, is to teach people how to write letters and how to visit a legislator. And I'm going to take a few minutes to, as soon as I finish this part of it, and teach you how you can teach other people to write a letter to a government official. Okay, the other thing I mentioned that you have to do in addition to getting organized, then you really have to get involved on almost a day-to-day basis. It's the participation part of it. It means that not only do you talk to a lot of people, but you write to your elected representatives. You make visits to them. You educate the public about the problems that you're having. And in terms of educating the public, I'd suggest there are 3 or 4 things that you need to educate the public about. One of them, you need to educate the public about the availability of the services that you're concerned about. What are the benefits that are available to them, and what are the costs, and what are the differences in the quality that people receive? So we've talked about there are 4 things that you have to know, and there are 2 things that you have to do. Let me quickly kind of summarize those for you. You have to know what the system is, how it works, who's who in that system, what the problems are, the process for making the changes. Then you have to do 2 things. You have to get organized, and you have to actually participate in the process. And what I'd like to do while we're waiting for the congressman to come is take a few minutes and we'll get involved in this participation in the process. We'll talk about how to write an effective letter to an elected representative. Get some people to help me pass these out. And you ought to feel free to get up and have some coffee.
IRTA, the NRTA, and the AARP. And now Congressman Harkin.
Pleasure to be here. Thank you. Let me set my coffee down here. Well, this is a nice day to be in the sunroom. All the sunshine and everything. Again, thank you, and it's good to be here. I'm sorry I'm a little late. I especially wanted to be here and to pay thanks to an organization that does a great job in Washington in terms of its lobbying efforts, but also in terms of the information that it's able to get to us as members of the Congress, and also the information that they're able to get back out to the people. The National Retired Teachers Association and the AARP, American Association of Retired Persons, just do an excellent job in Washington. I know that I personally, and I know many of my colleagues, rely upon them many times for exchanges of information, exchanges of ideas, and of course we rely upon them many times to lobby for issues that in which we are in agreement. And when we disagree, we just assume they go away and not be so effective. It's been said that there are three kinds of people in this world. There are those who talk about what happened, there are those who make things happen, and there are those who don't know what happened. And I can see by the fact that you're here today, although small in number, that you're part of that category number two that makes things happen. That you know what happens and you keep on top of it. And again, I do congratulate the American Association of Retired Persons for sponsoring this meeting. I think, again, it's one more example of their dedication in helping people help themselves and to help each other. Last year, Americans spent $206 billion. Now, I'm sure this has all come out today. I'll probably go over a lot of old territory. But last year, Americans spent $206 billion, or 9.1% of the GNP, on health care. $206 billion. Just keep that figure in mind. That's more than any other industrialized nation in the world spent. It reflects an increase of 275% in 10 years. If that rate continues, it's projected that we'll be spending about $368 billion, or a full 10.2% on health care by 1984. Now, I realize that those are just a lot of numbers, and it's hard to comprehend their full impact. As Everett Dirksen, a former senator from Illinois who has now passed on, used to say, $1 billion here and $1 billion there, and pretty soon it adds up to real money. So think of it this way, bringing it down into terms that may be a little bit more realistic than billions of dollars. At the rate that health care costs are climbing in this country, health care costs to the American public are going up at the rate of $1 million per hour, every hour of the day, 24 hours a day. So your topic today on curbing health care increasing costs is an important one, and I would be the first to wish you luck in finding solutions, and when you find it, please let me know. I think that example of the $1 million an hour also underscores the dilemma in which we find ourselves when the federal government tries to deal with the problem. And here's the dilemma. We have rapidly rising health care costs, which are literally pricing millions of Americans out of the health care market. They cry out, and they deserve some help. Secondly, those same rapidly rising health care costs make it extremely difficult for the federal government to respond. Everyone is for better health care, everyone is for more comprehensive health care, and everyone is opposed to paying higher taxes. And that's our dilemma. Plus, the added factor today, which I think is probably more prevalent today than it has been in the years that I've been working in government, in the last few, and that is that there is a feeling, valid or not, and I tend to think it's more not valid than it is, that the federal government ought not to get into health care, that is something that had to be handled only at the private level, and that there is no responsibility of the federal government to be involved in health care in this country. I think that's reflective of a general feeling of our populace that the federal government ought to retrench, that we ought to have less federal government, less intrusion in our daily lives, more freedom of choice, that kind of thing. Offering meaningful assistance to those hard hit by rising health care costs by its very nature does demand new outlays from the federal treasury, more outlays of federal dollars. However, I would point that there's another side to that coin. And on the other side of that coin is that if we do, in fact, get our health care costs under control, if we do, in fact, have a national health program in this country, that it will, and I know that every study done would show this, that in a few years there would be less expense to persons because the growth would go down in terms of how much they're spending. They would have more spendable income because they wouldn't be spending so much on health care. They would spend that money on items that would spur economic growth in our country. So the other side of the coin of the federal government outlaying the money is that, in fact, it could be more beneficial to our economy to release more private money for economic growth in the private sector. Your organizers today asked me to discuss briefly the various proposals before Congress, and I'd like to just cover those. I think they probably already have been, and I hope that I'm not being totally redundant. It's going to be very difficult to win passage for any of them. There's three basic programs of national health insurance. There's the Senator Long's bill, the Catastrophic Health Insurance Program. There's H.R. 5400, the National Health Plan Act, the administration proposal. And then on the other end, there's the Health Care for All Americans Act, the Kennedy bill, the H.R. 5191, Kennedy-Waxman bill. As I said, it's highly possible that none of these three will win any passage this year or next. And I'm sure that somebody has already pointed out to you, if you don't know it already, that the first president of the United States to ever propose a national health insurance program and make it part and parcel of his campaign, and I might add winning campaign for the presidency, was Harry S. Truman in 1948, 31 years ago, and we still don't have any kind of national health insurance. But Truman made that a part of his program in 1948. And so I don't know that we're going to rush into anything next year. And again, it all comes down to that lasting dilemma. In the final analysis, the plans have been judged as simply too costly by most Americans. So I hope that you'll see it as part of your job when you go home, as helping to deliver the message to your friends and neighbors that it's simply too costly, perhaps on the other side of the coin, to do without at least one of those. Sure, it's costly, but what's it going to cost us if we don't go that way? Again, it's like so many programs that we work on for the elderly. And I don't care, from a humanitarian standpoint, we have the obligation, of course, to provide a modicum of assistance to elderly to remain in their own homes. On the other hand, we found that economically it makes good sense. Whatever it costs to provide preventative health care, home health care, any kind of preventative health care, even though that costs money, you're going to save money later on because it's just not going to cost as much because people just won't get as sick as often. So what do? We can give up or we can press ahead to meet the challenge. I think we all agree that we've got to press ahead to meet the challenge. Certainly we can have disagreements on how best to do it, but I hope there's no disagreement that health care costs must, in fact, be brought under control. As I see it, we have two choices. We've got to recognize that we have finite resources, and we've got to set about rearranging our spending priorities to make room for meaningful health care coverage. And secondly, we've got to recognize that in the final analysis, the solution is in our hands. Whether or not we get health care insurance, what it will be like, what we do about our own health in this country, to a very large extent, rests with each and every one of us. And I'll get to that in a little bit. Let me talk about the first choice for the moment. and that is about reassessing priorities and what we want to spend our money on. In the fiscal year 1980 budget, all departments and programs were funded at just slightly above or below last year's funding levels. Every one of them. We were very good. The Carter administration, I think the House Budget Committee, were very good about keeping those spending limits right down to the bone. However, there was one that was not funded at last year's level and was funded at just about twice the rate of inflation in this country, and that was the Pentagon. The Pentagon right now takes 26 cents out of every federal budget dollar. It takes nearly 48 cents, or almost half, of all of the money that I vote to spend in the federal government. Because much of that money that goes out, of course, are entitlement programs over which I really don't have any control. Social Security, for example. I have no control over how much money goes out for Social Security. It's an entitlement program. Out of every dollar, though, that I vote or that we vote on to spend, nearly 50 cents goes for the Pentagon. I guess we have to ask ourselves a question, just, how much defense do we need? Enough to defend our country, but do we need enough to blow up the world 7 times over? Do we need another aircraft carrier for $2.8 billion? An aircraft carrier, and I had to know, I flew off of them for 5 years. An aircraft carrier for $2.8 billion, which I think is unnecessary in a limited war. And as Khrushchev himself said 20 years ago, it's a sitting duck in an all-out war. There's no way that an aircraft carrier is going to survive an all-out war. But I would just point out that $2.8 billion for one more aircraft carrier is more than 10 times the annual cost of everything that we do in federal nutrition programs for the elderly. That's Meals on Wheels, congregate meals, everything. Throw it all together. Amounts to 1/10 of that $2.8 billion for just one aircraft carrier. We're now going to be asked to build an MX missile system, which estimates range as high as $40 to $50 billion by the time it's built. Now, I'm sure you've all read about it. They're going to build this racetrack out in Nevada or Utah, and they're going to run these trucks around with all these missiles, and they're going to shove them in these holes and play all these games. $40 to $50 billion for that system. Others have pointed out that we could have just as an effective a system by using our existing submarines, and perhaps even building some more submarines with the missiles on them, at again about less than 1/4 of the cost of what it's going to cost to build that MX missile system. And I guess lastly, we must remember that waste and inefficiency can be trimmed in almost any program to make room for more important priorities than what we're already doing. I believe that I'm willing to make some of those changes, and I know others in the U.S. Congress are also willing. And it's important to have your support when we try to rearrange some of those spending priorities. Secondly, and as I said earlier, the other solution rests upon ourselves. Let me show you an example of what I mean about ourselves solving the solution. I'll just say, I want to ask you a couple of questions. I'd like to have a show of hands here. I want you to really be honest with me now, okay? How many of you are here today because you are genuinely concerned about containing rising health care costs? How many of you are really concerned about it? About containing, okay, thank you. Now, how many of those that raised your hands, how many of you smoke? Come on now, raise your hands. How many smoke? Come on, let's, okay, yeah, come on, a couple more. Build up your courage now. Well, that's very good.
After 25 years, I put my pipe away.
Good for you. Good for you. Well, that's very good. I ask that question a lot, and usually I get almost as many that raise their hands that are concerned about it, raise their hands and say they smoke. I guess it's an illustration. This crowd's very good. But reminds me of the comic strip Pogo, who once said that, we've met the enemy and he is us. In many cases, we are. Those same ones of you who raised your hand, how many of you follow a strict regimen of diet? How many of you follow a good, strict regimen of diet? That's great. Well, see, I'm preaching to the choir here today. Well, those are the things that we can do on our own, just a couple of the things that we can do on our own to keep health care costs down. Millions of Americans continue to smoke, and millions of course, as you know, increase the likelihood that they will get cancer and die from that, which is not only, of course, a deadly disease, but one that's very costly in its treatment. On the diet end, nearly 3,000 people die every year from simple vitamin A and niacin deficiencies. So we must practice these habits among ourselves. And also we must make sure that those among us who are poor and who can't afford it can get the help we can provide through nutrition programs to stay healthy. Every year, nearly 1.5 million Americans suffer, and 639,000 die from heart attacks, which are largely preventable through proper exercise, adequate diet, and good health habits. We spend $7.5 billion a year in medical costs and $12.3 billion in increased insurance premiums due to job accidents. So we must have safer workplaces. People always raise Cain about OSHA and trying to tighten down and make sure the workplace is safer. But when you see that we're spending $7.5 billion a year in medical costs due to accidents in the workplace, then maybe it makes a little sense to make those workplaces a little safer. We must continue to press for alternatives to nursing home care through programs like National Handyman, home health care, Meals on Wheels, those kinds of programs. It offers help to people in their homes so they can stay in their homes and live independent lives instead of being institutionalized. We simply must have more preventative care. As you've learned today, I'm sure that rising health care costs are not just a problem that hits the elderly. It often hits them hardest, of course, but it is a problem that hits us all. Fortunately, I think it's a problem that each of us in our own way can do something about, not only in the way we treat our own bodies, but in the response that we make in terms of our own families and what we do with our neighbors and what we do in our communities to encourage participation in these programs, to make sure that the knowledge is dispersed, to make sure that our children are taught the proper diet habits and, of course, taught not to smoke. I would just like to end up by just briefly outlining. And first of all, I won't unless it already has been. Has it been outlined some of the basics of the 3 different national health programs? They've already gone over that, right? Thank you. I won't go over it again. Thank you very much for having me here. If you have some questions, I'd be glad to try to answer them. Thank you.
Thank you, Congressman Harden. I think we have a question.
Fine, sure, I have a few minutes.
I understand that people who get food stamps, they're figured on the basis of 30 cents per meal. Have you tried to eat on 30 cents lately?
People who get food stamps are based on 30 cents a meal. I don't know that. I've never heard that figure. No, no, no. Food stamps, of course, are based upon your net income, what your net disposable income is in a family, taking other factors into consideration, such as health matters and things like that, children. But it's your net income, and it's based, the amount of money that goes into the food stamp is based upon I want to say a market basket of food and what it costs, but it's based, how much is given is based upon what those foods cost as determined by the Department of Agriculture. But I don't know of any 30 cents.
A young man who is physically handicapped, his only income is SSI, and he gets about $180 a month, and he gets $18 a month in food stamps. That's the extent of his thing.
He's on SSI, he's totally disabled?
Pardon?
He's on SSI?
Yeah,
He's on SSI.
and he gets food stamps, $18 worth a month,
Is he, he's single?
yes. That's,
Well, that doesn't sound right.
well, that's,
What are some of the other factors? Does he live at home?
no,
Lives by himself?
yeah. He's, got some rent subsidies, so, that pays 25% of his rent. The rest of it comes out of his $180 a month and takes quite a bit of that.
So he's, if he's on SSI, he has no other supplementary income. He doesn't work.
No, he can't work.
And he only gets 18 a month?
Yeah.
There's something wrong. There's absolutely something wrong. I don't know what it
They
is.
cut him off altogether because they said they had to reapply every year and he was 2 months without any.
Something wrong. What's his name? Can you give me his name and stuff, and I'll check in. There's something wrong there. I either don't know all the information or there's something wrong. I'll tell you, before I leave, you just write down his name and address. And if you guys have his phone number and stuff, just jot that down and give it to me, and I'll take a look at it. There's something wrong there. Yes.
Last week, we had a meeting up here, the hospital administrators, I understand. They were breaking their arm, patting themselves on the back because of what they were doing to cut down hospital costs.
Mm-hmm.
And yet, another report says the hospital costs have increased from last year 13%, which is greater, I believe, than the inflation percent.
Mm-hmm.
Now, is there anything else besides, you say that we are not going to have any, it's unlikely that we will have any action on insurance, health insurance. Is there anything else that we can do to help these poor hospital administrators to do a little better job?
Well, I think we are doing that. Let me just say that we just had a bill up on the House floor, the administration's hospital cost containment bill. 2 years ago, President Carter sent down a bill for hospital cost containment. At that time, I supported it. In fact, well, I still do. I'm going to explain that. Hospital costs had been increasing at just an exorbitant rate over the last 7 or 8 years, for a variety of reasons, which I don't think I have to go into. That bill was sent down to us, and it sort of sat there for a couple of years as we began to look at various ways of addressing that bill as it worked its way through the Ways and Means Subcommittee, then the full Ways and Means Committee. I'm sorry, the Commerce Committee, as it worked its way through the Commerce Subcommittee and the full Commerce Committee. When it finally came out, earlier this summer, this spring, I guess it was, when it finally came out of committee, and it was scheduled to be brought up on the floor, it kept being put off because they didn't think they had the votes to pass it. One thing happened in that 2-year period of time. The hospital started a voluntary program. I think they called it their voluntary effort program or something like that. And statistically, when you look at the figures, the hospitals in the last couple of years absolutely did a magnificent job in holding down their costs. In fact, I only know of, I could be wrong, I'm trying to remember now, I think there's only one hospital in the district that I represent, the 5th District, that in the last 2 years whose percentage was over the rate of inflation for those 2 years. Every other hospital in this district was way below it, in many cases half as much, 7% maybe, 6%, 8% increase in their costs, even though inflation, as you know, has been what, 10%, 11, 12, 13% inflation. Well, looking at that, many of us decided that, well, you know, why fix something that's working? If in fact their voluntary effort program is working, to be sure, I'll give President Carter this much, and the administration and the bill that we had, that without that bill, I don't think the hospitals would have done it. I think it was like holding a hammer right over their heads and saying, listen, you better do something or else it's going to fall, and it's going to fall very hard. I think the hospital administrators got together and put a lot of effort behind that, and I think they're to be commended for it. Now, when the bill came out on the floor, many people said, well, you know, again, why fix something that's working? there was a substitute bill offered by Mr. Gephardt from Missouri, the Gephardt substitute, which basically monitors, it sets up a commission to monitor the voluntary effort program. They must report at the end of next year if in fact that voluntary effort program does not continue on the same path that it has been continuing. You can bet your boots we'll come right back again next year with a stiff hospital cost containment program. That was the whole thing behind the Gephardt thing, was as long as they're doing it, if they can continue to keep their increases below the average rate of inflation, that's fine with us. And we don't care, you know, let them figure out how to do it. That could have been one of the hospitals. In fact, I'm not going to mention any names, but there was one hospital nearby that did in fact go over that figure. I've been told by people from that hospital that it was due to certain building factors and things like that. And when you carved out the one-time costs that were incurred, that it wouldn't have been that high. I can't vouch for that one way or the other. They could have been just talking about that one hospital, though. No, I think the national figure, maybe someone can correct me, was down around 10%, 11%, huh? About 10 to 11%, something like that, was the national figure. And under the Gephardt proposal, they must maintain that. They have to maintain that. And obviously, if the rate of inflation goes down, which we hope, if it should go down, then that figure also has to go down under the Gephardt proposal.
Isn't it true that this effort by the hospital association pertains only to certain states, it's not nationwide?
Well, I think it's nationwide, although I think some states were not very effective in controlling their costs. I'm trying to remember the debate on the floor now, and it seemed to me that there were 2 or 3 states that stuck out like a sore thumb. Iowa was not one of them. I can't quite remember what states those were.
Some states have special laws urging hospitals to do that.
Yeah.
That makes quite a difference.
That could be true, too. There could be individual state laws that address that problem in their states, too. There sure could be. I don't know if Iowa has or not. I don't think so. But hospital cost containment, it's an issue that's still very much with us. And but I've again, as I say, as long as the voluntary thing is proceeding fine. Also, I don't know that I've ever really been absolutely convinced of the argument that just by controlling the hospital costs that you really control the costs of health care. I mean, there's just so many other factors involved, whether it's food or labor or